At the outset, I would like to thank ISOT organizing committee for inviting me for this talk. So I am asked to speak on robot-assisted kidney transplantation in obese patients. Now, if you see the epidemiology data of USA, the 20 to 50% patient on dialysis were obese. Grade 3, like BMI more than 40, we all know reduces the opportunity to access transplant. Kidney transplant increases the longevity and quality of life in obese patients. We often see, even in India, obese patient in our program. Many international patients which we are getting now from the African and Central Asian countries are usually obese. If you see the KDIGO guideline, they very categorically said, we suggest that candidates not to be excluded from transplantation because of obesity. We suggest weight loss intervention be offered to candidates with obesity prior to transplantation. And if you see the other guideline, they recommended, we suggest that kidney transplantation either from a diseased or living donor is the optimal treatment for people with BMI 30 to 39 and end-stage kidney disease who are otherwise considered suitable for kidney transplantation. We suggest not delaying wait listing or transplantation solely on the basis of increased BMI in people with BMI of 30 to 39. And even they have even suggested their paper that you can do the bariatric surgery and transplantation simultaneously, which I doubt. I think it's bariatric surgery should be done first, and after some time you offer the transplant. So the KDIGO guideline in detail says should not automatically exclude a patient for transplant to assess their body habitus and related comorbidities, counseled for poor wound healing post operative period because of increased complication in hernias, should be offered weight reduction intervention, careful monitoring and adjustment of immunosuppressants, higher risk of serious pulmonary and diabetes related complication, higher risk of delayed graft function. So open transplant, we have been doing open transplant in these patients. Even in India, the central obesity is more, especially in ladies, and they are short statured. And the kidney is situated quite deep in the abdomen. Believe me, I have done so many 5,000 transplantation. And in obese patient, it is still always a struggle because you have to put the retractor and you have to need assistant to go deep to work there. You need longer instruments, more assistants are required, and there is a higher chance of surgical site infection, wound dehiscence, incisional hernia, more respiratory and serious complication, increased incidence of deep vein thrombosis, and longer hospital stay. But then the robot came, and we also started doing in 2015. And actually, I made a mistake of starting robotic program in obese patient because that was the real indication. But I tell you, robotic transplant, even in obese, is not as easy as you do in a normal weight patient. But it is a boon for obese patient, and you can do it once you gain significant experience, as we have done almost 480 robotic transplant by now. And what are the advantage? You give very small incision. It's a 3D vision. You see 5 to times magnification, 7 degree of movements, no tremor, ease of surgery, fast and easier suturing, early post-operative recovery, very low SSI, short hospital stay. So it has all the advantage, and it is a real indication. And I must say, for obese patient, robotic kidney transplantation is a boon. So what are the pre-op? It's very important to pre-op selection and counseling. Counsel for the increased risk of complication. Screen for obstructive sleep apnea, GI reflex, aspiration risk, difficult airways. All these things are quite common in obese patient, especially in Indian obese patient with short neck and truncal obesity. Weight loss pathway, nowadays these drugs are available and we have seen they are working very well. And I hope that bariatric surgery will disappear very soon, as the gastroduodenal surgery for ulcer has disappeared with the development of cimetidine. Diabetes optimization, for we should check their, because most of these patients are not moving much, most of the time sitting and eating, so they are quite frail. So we have to rehabilitate. Before that, we should start the respiratory exercise, screen for thrombosis, and VT risk stratification is very important. We must image by CT scan their penis, their visceral fat. Is there associated hernia? Sometimes is not seen, but in CT scan you can see it. And you should also look for their pelvic vessels calcification, atherosclerotic changes, limb ischemia, because we have to go there and operate and we have to fix the kidney. So we have to see where we are going to fix the kidney. They must have had PD catheters, and whether they are widening well or holding urine, because very difficult to know clinical examination. So you have to investigate further. Their CVS and pulmonary assessment is very vital. Diabetes optimization is very vital, and good pre-anesthetic checkup. And we do MDT. We meet everybody, discuss, tell the patient, record everything, and take in detailed consent. Drugs and antibiotics are also very important, because you have to see their weight and then choose all the doses. Intraoperatively redosing is very important if the surgery is taking longer time. Induction and immunotherapy. Drug, because these immunosuppressive drugs are also behaves very differently in these patients. So frequent monitoring of tacrolimus or everolimus or the mycophenolate dosing is also very important, so that you can give appropriate doses. You should look for drug interaction, because they will be taking so many drugs, so make sure that this part is also taken care of. And very important is immediately after the operation their mobilization and physiotherapy should start. That was the first case done by for the obese patient to 2007 in Chicago, and that started the interest. And that was a 29-year-old CKD patient whose BMI was 41, and 7 centimeter midline incision was given, and you can see the blood loss was only 50 cc, and the kidney started working immediately. So, and these obese patients have general consideration, like you have to tuck their penis so that you know where you are going to put the port, and you can plan the port placement properly. You should use bariatric table, longer belts. You should, best thing is put the gel pad so that it stick to the patient and they don't move. And you can avoid lot of padding to avoid neuropexia. And you should also remember their bony landmarks, so that while you are putting the trocar, you know how far you are away from them. Anesthesia, we have a very good anesthesia team, and they look after everything, and they need a lot more care than the usual patients. Port strategy, that for obese patient, we use gel port. Like most of the other robotic transplant, we use any hand port to cut the cast. We give a small pharyngeal incision, drop the kidney, and do the whole operation. But obese patient, most of the penis is in that area, so you can't do it. The best place is to put it the umbilicus, put the gel port, and then you plan the port placement. And the gel port is two ports goes through the gel port, the camera port as well as the assistant port. And this helps also quick delivery of the graft into the iliac fossa, and otherwise it takes long time to do that. Docking is also important. You should see that how big is the abdomen, or especially in Indian females with lot of truncal obesity, you have to place with the XI placement is very easy. and then just have to see whether you have to go to the above the umbilicus, below the umbilicus, how far is the landmark that helps us in putting the port properly and they don't collide with each other. And sometimes you need extra bulldogs because vessels are may not get compressed one single bulldog. Bed preparation is also because a lot of small bowels are over the iliac vessel, so you have to use the extend tendon bread position. And sometimes in what happens that mesentery is too short and full of the fat, and sometimes very difficult to remove the bowel from the external iliac vessels, and twice we have to abandon the procedure because we tried and tried. We put the sponge, put the with the hand port, try to keep the bowel away, but finally we abandoned and did the open operation. Now we are doing extra peritoneal robotic transplantation and our results is going to be published next week. And so with that probably it might be better, but making extra peritoneal space in obese patient is also very difficult because sometimes we have to do extra peritoneal robotic prostatectomy in these patients because of the glaucoma. We can't make the position and it's not an easy thing to do. So, and it is also very important to mobilize the cecum and the sigmoid and create a space to keep the kidney. What happens, there is so much of fat and kidney is sitting here and vessels are here. So bring them together. We have to use the fourth arm to push it down so that they can come together. So these are the various problem we encountered in doing patients, but it is doable. It is, as you gain experience, it is not very difficult. And you have to control all the lymphatics to take care of the lymphocytes, keep extra bulldogs ready, and if need be, press the kidney with the fourth arm to bring the anastomosis. I know the donor is a contraindication, but I was invited in Mumbai to do a obese patient whose BMI was 46. But when I reached there, I saw the donor was also obese. But now everything was planned, so we had to go ahead. Both patients did very well, and now the lady who was sitting lying down all the time is moving around and quite happy. We get so many patients from other countries and they are really obese. Because they are some of them short stature, so BMI goes very high. But after the transplant, some of them made very good recovery, and you can see how the incision goes down immediately post-op because there's so much of fat, and you are doing very good incision repair, wound repair, so that they should not develop hernia. Abdomen looks very bad, but after some time it becomes better. So you put the gel port, and then you deliver the kidney, and then also deliver some ice over the graft. And initially you have to keep the pneumoperitoneum higher while you are doing the placing the graft and doing the anastomosis. But once the graft is revascularized, you have to bring the pneumoperitoneum to 12 or 10 so that kidneys perfusion is not impaired. Once you set up everything, then suturing is not difficult. Then the whole operation goes as you do it. And we use 6 euro Gore-Tex sutures, and some of times they have atherosclerotic vessels. It's very important you study the CT scan and you know where you are going to put it. And here probably in future augmented reality will matter because that will tell you have to stick it here. And but once you open up and you see atherosclerosis, it is very important to fix it then and there. Otherwise, dissection will be a problem. So exit strategy, when you have done it, then desufflate slowly, inspect for bleeding at low pneumo. Proper closure of hand port side is very important, otherwise they will develop hernia. Facial, this port side closure is also very important. And you should follow the ERAS protocol, which is now being practiced most of the centers. Sequential limb compression to take care of DVT, low molecular weight heparin, early embolization, and chest physiotherapy. Look for calf tenderness, monitor pelvic drain, consider early. If there is a more, then you can give it octorite to bring down the lymph collection, wound surveillance, negative pressure dressing. Most of the time there is seroma collection, and you can either aspirate it or you can open and put some drain negative pressure dressing, and that takes care of it. These are the various patients, you can see it, we have done it. And now let's see the literature. The literatures nowadays, plenty of literature supporting the robotic transplant in obese patient, advocating robotic transplant in obese patients. So this is 10-year experience from single center. From 2009 to 2018, they did 239 patients included, and then median BMI was 41. almost 70% got the kidney from living donor. Operating time was 4.8 hours. Warm ischemia time was 45 minutes. Wound complication was 4%. Surgical site infection was 1. There was 7% graft failure, mainly due to acute rejection. Patient survival 98%, graft survival similar, and it concluded that robotic assisted kidney transplant is safe, minimal SSI risk, excellent graft function and patient outcome compared to the, and they compared with the national data. And if you see that serum creatinine is quickly comes down and GFR is very good in follow-up. And as they learn more experience, case volume increases, their warm ischemia, re-warm ischemia time also decreases. This is another publication come out recently where they compared obese versus non-obese donor, and they have also concluded that it's a very robotic transplant is a very safe operation. Another study where they compared robotic kidney transplant of recipient BMI more than 40 or greater to the UNAS registry, and they showed that its results are comparable. And if you see it here that the serum creatinine, there is no, and when they compare with the open kidney transplant, there was no difference in serum creatinine follow-up at 6 months, 1 year, 2 years and 3 years. GFR was also same. But what they have shown that wound complication is less. So that's very important, that, and wound complication is very common in these patients. So that's how the results are very good. This is another publication again showing that robotic kidney transplantation is safe and has equal results or rather better results, and complication rate is less. This is the single center expensive of disease donor, and you can, and they have put the patient between 30 to 40, 41 to 44 and above 45. If you see it here, patient survival and graft survival is less when the BMI is more than 44. So I think this is the European experience, which has again showed that results are comparable, and they did not have any difference between vascular anastomosis in all three group of the patient, and their kidney function was also same in all three groups of the patient between 30 to 35, 35 to 39 and above it. So in nutshell, I will say that wound complication is a major problem. Even in robotics, sometimes they develop wound complication, but since wound is small, there is no retraction, so it's very low. It is feasible, doable, associated with least complication, but plan it well. Look for pelvic vessels where you are going to fix it. And this is the one patient I did in 2016 whose BMI was 46, and he was refused transplant in Singapore and Bangkok. So we did it. He did well, but in COVID time and he was from Myanmar. So COVID time he developed hernia, but he couldn't come to any hospital. And when he showed me the picture, I said, "You come here." But he came after 2 years 2024. At that time, hernia was so big that even our very famous hernia surgeon refused to operate him. So I would like to conclude that kidney transplant in obese patients are safe and should be offered for better quality of life, comparable graft and patient survival, and robotic transplant is the way to go. And once transplant is done, quality of life improves, the better motivated, and they lose weight. And this is the patient I want to show you that after that she was very happy and she started losing weight, and in follow up here 2 years later I couldn't recognize her, and that's how the incision was looking. Thank you.